Aaron be here? We'll start with the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning, everyone, and welcome to the Shawnee County Board of Commissioners work session. It's Monday, June 12th, and today we have Teresa Fisher, our Public Works Director, and our Public Works.
No.
You don't want Public Works.
That is Kurt's domain.
You got enough on your plate. Anyway, so I'll let you start out.
All right, good morning, Commissioners. I'd like to welcome you and everybody in attendance and those listening online to the Board of Health meeting today. This is our semi-annual board meeting, so we'll call this our spring and summer edition. We're excited again to be bringing these back. We're trying to go into a semi-annual, so we'll do one in the spring and summer, and then we'll do one more towards this fall. But we've got two agenda items today that I think will be of interest to you and the public. So I will do some brief introductions and kick us off then. So you'll be hearing from Carrie Delfs, who is our Clinical Services Division Manager, and Manya Schmidt, who's our actual provider today from our Family Planning Program. So our Family Planning Program has been in existence for just over a little of a year now, and so they'll be doing really kind of a year in review, looking at the program, where we've come from, where we're going, who we've served. I think you'll enjoy hearing their updates. And then we'll also be hearing today from Craig Barnes, who's our Division Manager of our Community Health Outreach and Planning Division, as well as Dr. Aaron Luck, our County Health Officer, and they will be doing a look at our county health rankings, which were released in late April. So they will do kind of a broad overview of the county health rankings in and of themselves, and then they'll be doing a deeper dive into our specific county health rankings. And I know both sets of presenters will be happy to answer questions as we go. And with that, we'll kick it off with this group. Good morning, Commissioners. Carrie Delfs, Clinical Services Division Manager. We're so happy to be here this morning to talk about this first year in family planning. This was such a process to get this going. We were funded through our Aid to Local grant for the state fiscal year 2019, I believe, with plans to get the program up and going. With the pandemic, though, that certainly put the brakes on things. So we were happy to resume this work and finally get services started. So just a quick overview of Title X. Again, this is the federal funding that flows to the states. And then, as I mentioned, we use that Aid to Local grant process, and that's where we receive part of our funding for this program. So these Title X priorities are developed by the Office of Population Affairs, and we're really focused on the health equity pieces, expanding access to care, and then delivering high quality care. All services provided in these programs are voluntary, confidential, and provided regardless of ability to pay. For a lot of the patients that we see, this is the only source of health care that they receive, or health education for that matter. All Title X programs kind of have these same areas of services, the focus being on pregnancy prevention and birth spacing, pregnancy testing and counseling, assistance to achieve pregnancy, infertility services at a basic level, STI testing, and then other preconception health services. So you can see this good-looking group here at our ribbon cutting in April of last year. As Teresa mentioned, we've been providing services a little over a year. We started in about mid-March, kind of a soft opening, if you will, before really opening up that schedule. So a little information about the patients that we've seen. This is unduplicated patients from March of last year through March of this year. And as you can see, our clients by age, we're really focused on that
reproductive age. We've also got race and ethnicity here. Another measure that all service sites collect is information on household income and size. This helps to determine the sliding fee scale discount that patients receive. So as you can see here, a majority of our patients are at or below 100% of that poverty level. Anyone up to 250% and below would receive a sliding fee discount, and then 250 and above would not receive that sliding discount. And again, a majority of our patients are uninsured, so again, this is where that access piece is important. And then I'm going to turn it over to Manya to speak to some of the clinical data, some of the services that she's provided within the program.
Good morning, and thank you for the opportunity to be here to speak with you and share what we feel like has been a great success in our first year of providing services in their family planning clinic. I want to expand a little bit on who we served and how we served them. When we did the ribbon cutting, one of the things I spoke about was in my taking this position was that I really wanted to provide services to the people who were falling through the healthcare cracks. And I think the information that we've provided in the data really shows that that goal has been met, and that fills my heart. I love being able to serve people who wouldn't otherwise be getting services. And in the clinical data, you can see the different types of contraceptive methods. As a Title X clinic, we have to provide all of the contraceptive options. That's one of the requirements in our clinic. And their focus is to provide information and counseling and same-day service with an emphasis on using the long-acting reversible contraceptive options. And you can see there with the hormonal implants and IUDs that we are really meeting that Title X goal of utilizing those methods for people. And interestingly enough, those are the ones that are the most costly. So in terms of caring for people who are uninsured or underinsured, those methods are oftentimes out of their financial reach. So we're really hitting the nail on the head in that regard. And if you'll look at the total number served and the number of contraceptive visits, those numbers don't always match up. Some people leave, obviously, without a contraceptive option. They come and we do all the counseling. Some people come for preconception care, so obviously they're not going to leave with a contraceptive option. So that's part of the Title X care, as well as to provide preconception care with the focus of achieving a healthy pregnancy, having appropriately spaced pregnancies, and getting the best start possible for women desiring a pregnancy. All right, next. You can see also that we provide different types of screenings that go along with just our contraceptive services. These are all appropriate screenings based on evidence about age appropriate and risk factors. That's also a component of a Title X program. We do STI screenings in the clinic, in the family planning clinic, as well as our STI clinic, as part of age-appropriate screenings and sharing that information about what is appropriate and when screening should be undertaken. The other screenings are really social determinants of health, tobacco, alcohol use, substance abuse, drug use, living environment, access to food, intimate partner violence, trafficking, depression, and certainly you don't have to live under a rock to know that depression screening is certainly something that's huge. And honestly, I've been kind of astounded by the responses that I've gotten on just the brief depression screening that we do in the clinic, about how many people are reporting depression symptoms. All of these things have really led us to an opportunity to identify community partners where we can refer on. Obviously, what I do is fairly limited, so it's been essential when I identify a need that I have resources in our community to refer people on for expanded services, primary care, obstetrician, gynecologist, mental health, those sorts of things. So that's been exciting to me to be able to reach out to the community and identify partners that are willing to work alongside with us to care for the patients. After our first 6 months, we did a client satisfaction survey, which is also one of the requirements of Title X, and that was conducted in October of '22, and we did paper surveys, excuse me, in English and Spanish, and we also had QR codes linking to electronic versions. We evaluated a plethora of measures, going from how easy is it to make an appointment, to how were you greeted, to did you receive your method that day, those kinds of things. And really the feedback that we got was overwhelmingly positive, and we really received some great comments about the care people received and how appreciative they were of the care that they received. And we are currently in our second evaluation cycle right now. So hopefully we'll get the same glowing reports this time. So I'm going to let Carrie finish up here with where we're headed in our next 1 year, but I want to thank you all so much for the opportunity to do this. This job fills my cup. Coming back from retirement, this job people said, Manya, you're still working. And I said, yes, but you know what? I love what I do, and I love serving the people that I serve. So thank you so much for the opportunity and being supportive of our clinic.
I have a quick question. You
Of
mentioned age.
Of course.
You've mentioned age-appropriate screening. What does that mean?
Well, like, for example, obviously, a 20-year-old doesn't need a mammogram.
Okay.
So a woman who I might be seeing who's 40 or who has high risk factors for breast cancer, positive family history. I do a comprehensive family history as part of my intake. And like for chlamydia, women or people, I see primarily women, but I do see men, but primarily women, age 15 to 24 should have annual STI screening. So I share that information with them so that if they haven't had that, I say, you're in that age range where you should be having this appropriate screening, and I can certainly provide that today if you'd like that.
Okay. Thank you. One other thing about the depression. Sorry. Are you seeing an increase in that, or do we have a baseline?
Well, I don't, honestly, Commissioner, I don't really know what a baseline is. I hear, obviously on the national news, every news show you hear or see on TV is talking about, depression and so I don't really have a baseline because I honestly, when I was working before in my job before I retired, that really wasn't part of what I was doing. I was in a very specialized clinic. So we have 4 questions on our intake form, but I'm just, like I said, I'm just kind of astounded about how many people answer those questions as some days they can't stop worrying. Some days they feel sad and don't want to get out of bed or do anything. Some days it feels difficult to do activities of daily living. I've just been kind of amazed, honestly, because people come in and you chat with them and you think, oh, they're good. And then you start looking at their form and it's like, oh, well, can you tell me a little bit more about that? And obviously, if, there's significant things, I do a more comprehensive screen. And if their score is a certain number, there's a PHQ 9, which is 9 questions. Certainly if their score is, indicates that they need further help, I'm letting them know what the community resources are to get help. Because that's outside my scope of the services I provide, but that's why I want to know who's in the community who can help these folks.
Well, thank you. Thank you.
All right, to wrap up, we're kind of looking ahead. We would expect to have a program site visit with KDHE at some point within maybe the next year or two. We also look to expand our Information and Education Advisory Committee. This is a group of, right now we've got myself and Manya, we've got some partners, we've just added a client, but really we're looking at all of the information and education that we would provide to patients, so like our fact sheets, our consent forms, referral information, to make sure that it's appropriate for the community that we're serving. Is it inclusive? Is it easy to understand? So this advisory committee reviews the materials that we provide. And we would like to add some more clients to it, really get some representation from the people that we're serving. We'd like to continue to build on those collaborations with our community partners. As Manya had mentioned, we've got some great partners in this community, and being able to connect our clients with them has been wonderful. And then just getting back to kind of our routine quality improvement activities, identifying places in our workflow where we could improve or streamline things. So those are the type of activities we're looking forward to in the next year. Happy to answer any further questions.
Questions?
No, thank you.
All right.
Thank you very much.
Thank you.
It sounds like they have to leave. They have clients, so.
Thank you. Thank you, Manya. Thank you very much.
All right. Good morning, commissioners. So I'll get us kickstarted here, just to kind of give it a little bit of an overview on county health rankings. I'll turn it over to Dr. Locke, and she's going to kind of go into a little deeper dive on some of the specific rankings and factors, pull out the kind of the data a little bit more specifically for you. What I do have that I wanted to provide each of you, and I'll get Jim one as well, because I know he's super intrigued in all of this. There you go.
Thank you.
So the document that I just provided to you, each year, the Kansas Health Institute does a great job of providing a two-pager. That's that first document there. On the front is a breakdown of the county health rankings for this year, and you can see how we've compared then to it in the years prior. On the back side of it, it breaks down a little bit further into both our health outcomes and our health factors, specific indicators and rankings within those sectors, if you will, that have the highest that drive those rankings a little bit more. And so this is a great document that KHI provides. We use in any of the outreach opportunities that we have to talk about the health rankings. This goes into a little bit as well into what we add in when we review our community health needs assessments on an annual basis before we go through that cycle every 3 years. So we use the data that's included in that from the Robert Wood Johnson Foundation and the University of Wisconsin Population Institute that does the county health rankings to every year kind of assess where we are, because we do our county health rankings every 3 years. So this gives us a little bit of a snapshot. One thing that that you all have heard me say numerous times when we talk about the county health rankings is data is a little delayed, right? And so the data that we're receiving, the rankings that we have here that are provided to us, is all based on data that is typically around 2019, 2018, or sometimes a little older. So what you're seeing is impacts for policies, system changes, environmental changes that we put in the years 2010 through 2015, 2016, and then everything that we put in place, any change that we do, takes a couple of years to be able to truly assess what that difference is. And so what we're seeing now are the impacts for the data that was collected in 2018, 2019, those years, for system changes, policy adoptions, and things of that sort that we did in the early 2010s. So I always want to make sure that I provide that little caveat so that you see data does take a little time to collect. And of course, you know, when we institute something, a policy change, say sometime this year, we won't have the data to directly assess that except for environmental observation real time at that moment in time. So, All right, so the next slide I want to show, oh, we might have reverted back to an older slide deck. Okay, so what I wanted to show you guys was a video. I'll provide that to you guys afterwards. But what it did was it provided a little bit more of an overview of the model, if you will, for how to do the county health rankings. So here, what this is, is basically the model. Each one of those sections that you see on that sheet that you have breaks down the health outcomes, whether it's length of life or quality of life. Those split the two 50% that make up then the health outcomes. Each one has some subsequent measures underneath them that are measured. As you can see, 2019, 2020, we didn't have, the data shifted for 3 of those measures under quality of life. So data is constantly shifting and evolving, and so the models and things shift with those so that we can truly analyze as close as we can and get a semblance of how our community is doing in real time. New data becomes available, new systems are created at the federal level to analyze more data as more things pop up to the top that we want to make sure that we are looking at. Same thing for health factors. What you can see is the percentage breakdowns in each of those 4 areas that make up the overall health factor score. So 30% of the overall health factor rankings is for our healthy behaviors, 20% there for clinical care, 40% for social and economic factors, and then 10% for the physical environment. One of the things that we have routinely scored very well on is our clinical care here in our community. We have 2 great regional hospitals. We have the VA here as well. So our clinical access has been always very good in our community. One of the interesting things that you'll see on the clinical rank for this year is that we did drop from a 3, which is the highest that we had been, down to a 9. Interestingly enough, all of our indicators par 1 actually improved or stayed the same. So I'll talk a little bit into how we analyze and interpret the results here in a couple of slides, but I just want to point out that other communities, when you're ranked against 105 communities throughout Kansas, some are also improving based on what they're putting in place, and so they may be improving at a higher rate than maybe sometimes we are here in Shawnee County. Okay, so what determines health? So this is always a really great slide to look at. The new kind of phrase that is catching, traction in public health, and really, I guess, over the last couple of years, has been that zip code is truly more important to someone's health than their genetic code. And I think this slide here really personifies that to a T. As you see here, 20% healthcare, the preventative health measures that you're kind of taking when you meet with your doctor, makes about 20% of your health. Your genetics, then, the other 20%, but really where you live, those social, economic, and behavioral factors play a much bigger part in how you can live based on your access, based on access to whether it's to clinical care or to recreational opportunities or to behavioral health or even to food, healthy food, rather than, so whether we have food swamps versus food deserts versus, an oasis of healthy food options. And so one of the great things I thought that Robert Wood Johnson and the Wisconsin Population Health Institute did this year was they focused a lot on civic health. That was the focus for this year. And one of the things that I think, and I would say I would pride ourselves on and look to you guys for the great job that you all have done as our commissioners, as well as over across the street with the city, is our civic engagement, our civic and participation, and the civic infrastructure that we have in our community has provided a great avenue for our community to provide feedback to us. But one of the things that we have done as a health department truly over the last 5 to 6 years is also utilize that civic infrastructure that we have, the great parks, the library that's centrally located, and things of that sort, to provide an opportunity for us to actually go to where in our community the biggest issues are and get that participation directly from the community. And so we have created through that a whole lot of unique strategic partnerships with a host of community organizations throughout all of Topeka and Shawnee County that has provided us an opportunity to truly assess that 60% there, those social, environmental, and behavioral factors, to figure out where we can directly put together policies, systems, environmental changes to make the biggest impacts on our community and improve ultimately those health factors. So one of the things that you saw then on that sheet in our health factors is that was one of the areas where we had an increase. And actually that ranking of 45 is the highest our community has ever seen in Topeka and Shawnee County for a health factor score. And I think a lot of that is credit to the work that you all as commissioners have allowed us to do as a health department and the impact and the civic participation that we have also gotten from our community to truly give us a qualitative assessment of what the needs are, what the barriers are, so that we can drive appropriate policy change.
Craig, have you
Yeah.
ever taken any measures to actually right-size the Shawnee County health rankings to appropriate size? I mean, these health rankings are very biased against Shawnee County. It's unfair.
Yeah.
When you compare Shawnee County to Allen County puts in one food, they address a food oasis, and suddenly their health rankings will shoot right up. Meanwhile, based on our population, we would have to have monumental things that would occur, once in a lifetime things that would occur for our health rankings to shoot up. I mean, it's an unfair ranking. I think it's a good maybe milepost. It's maybe a good guidance to where we should be investing our resources, but it's an unfair comparison. And I don't know if you've ever advocated on behalf of Shawnee County that we should be comparing ourselves to the urban counties, whether it's Wyandotte, Johnson, Douglas, Shawnee, Riley, Manhattan. There you go.
Well, hey! So Dr. Locke will talk a little bit about this, but you honestly asked a fantastic question. And truly, that is one of the things that we do try to look at. And for us, we honestly, as a health department, don't lay a lot of stock into the physical number that we see there. It's great. It's a good conversation starter, to your exact point. For us, we dive a little bit deeper into the data, but also for us, it is the conversation starter. We use it as an opportunity for us to go into the communities and truly, this is all quantitative, right? From larger data sets, phone surveys, BRFIS, which is the Behavior Risk Factor Surveillance System, things of that sort. For us, as a health department, one of the biggest things, and I think that you saw from a presentation a couple weeks back from about our MRC, I pride ourselves a lot on is that civic participation. And the ability for us as a health department to dive into these factors as starting points, but dive farther into the community to assess those needs with the community and get a lot of good feedback directly from those individuals. We have a great set of volunteers that come through that provide a lot of continual feedback for us, and those community partnerships that I talked about. Those have allowed us great opportunities to meet with content experts in specific areas that we know we need to address to figure out then tangible and actionable interventions that we build into this great document, which is our Community Health Improvement Plan. And from there, it allows us to then make an impact, and then that's how we look at and try to gauge our success that way. A little bit more so than the county health rankings. But one of the great things about the rankings, they added that roadmaps aspect a handful of years ago, is it does provide you actionable interventions and things of that sort that you can look at that are best practices that have been successful in improving health factors or health outcomes in other communities across the entire nation. So that allows us to take that, try to find something without trying to create something brand new. We're able to kind of borrow from other communities that look like us, right, to figure out what interventions were successful there so we can duplicate some of those similar efforts. But that's a fantastic question. Yeah. So I kind of already talked about this a little bit, but on the interpretation of results and the rankings, to your point about gauging between Allen County or Osage County, which is, I think, just to the south of us, but in the top 10, a much smaller county, we can't really compare ourselves too well against Osage County just because of the demographic differences. So one of the things that it's important to look at, obviously, is change of values in our county, but also other counties. Say Allen County, for your example, put in a brand new grocery store to address a food desert. Their food insecurity ranking would drop significantly because they have more access to healthy foods. Same thing with putting in new trails, access to recreational opportunities, or complete streets protocols, things of that sort. So for us, so large, we would have to put those policies in place, and they would have to take place over multiple years to see the same infrastructure changes that some smaller county might see. That would shift their ranking differently like that. Times and trends, data timeliness, I talked about that. You know, we're looking at data for this year. This is a 2023 ranking that's based on data that's from the 2018 through 2019 that is really impacted by policies and changes that we made in the early 2010s between that and 2015. So, okay. I'm going to turn it over to Dr. Locke now, and then you'll see me again kind of at the end to kind of talk about some next steps. All right. Yeah.
Yeah, I was the same. That's why I put the slide on here. I was like, I want to know what Shawnee County looks like compared to other big counties. And so, yeah, glad we had that. We're gonna run through them, and we're not gonna focus on all of them because there's a lot. And there will be no pop quiz at the end, so you can relax on that. And so let's just go ahead and dive in. As Craig talked about, we have a ranking for outcomes and we have a ranking for factors. And outcomes sort of represents the health of our community right now, and factors sort of project where our ranking of that outcome could be in the future. Those are the things that if we modify them, our outcomes should improve. I think this slide is really interesting in that it does really point out your zip code and your education and your wealth, your access to opportunities, and how that can make such a difference when we compare Johnson County and Wyandotte County, who are right next door to each other, and historically separated demographically. Johnson predominantly white and wealthy and very well educated, and Wyandotte is not. And so you can see how that works in the rankings. And we will actually touch a little bit on how that sort of plays out in Shawnee County also. I'm not sure if Craig had mentioned it, but as our outcome is 79 out of 104 this year, but when you actually look at what we were using to determine that, our factors there didn't, or excuse me, not factors, but our measures there didn't change that much. And so as Craig and I were talking about, it really, we think that we dropped from 54 to 79 this year, more because other counties improved and less about our numbers actually shifting, which I know his previous slide talked about. That can happen. But the good news being that our factors have improved from 56 to 45. So we've seen some shift there, which is hopeful. Okay, so as we look at the health outcomes, that 79 ranking does put us in the bottom quartile for health outcomes. They, in particular, I want to focus on our length of life, or stated another way, our premature death, and how that is contributing to this outcome. The other big factor is quality of life, which we'll touch on a little bit. Okay, so we're starting here with a graph, and this is looking at premature death, calculated using years of potential life lost. And so the assumption here is that if you live to be 75 years old, you have lived a full life, a productive life, you have contributed to society. If you die at 75, that is, I think we all want to live to be more than 75, but we would consider that to be sort of a normal time that you might die. If you die when you are younger than 75, there is loss there. Loss to you, to your family, but also to our community and what you could contribute in so many different ways as a citizen. Obviously, the younger you die, the more you contribute to that. So if you die at age 74, 1 year of life lost. You die at 40, 35 years of life lost. You die when you are less than 1 year old, 74 years. And so I kind of hammered that point home. But in Shawnee County, we do have a higher years of life lost than both Kansas and the United States. And as you can see, that has been a trend here for quite some time. And in the last few years, it does seem to be rising. So you might wonder, okay, why are people dying? Fairly typical reasons that we know to die. Cancer, heart disease, like a heart attack, an accident. Now, this accident could be something unintentional, like a car accident. It could be intentional, like a suicide or homicide, and we will touch on suicides in a few slides. The lung disease, like COPD, something that can be caused by smoking, and then, of course, diabetes, which itself can contribute to things like heart disease. The good news here, when I look at this, is that I see modifiable causes of death. I see these things as we can screen for them, we can get in front of them, we can treat them, and we can actually make an impact on these causes of death. And you might think that we are all dying equally in Shawnee County, but that is not the case. As I had pointed out, Johnson and Wyandotte, we have a similar disparity here in Shawnee County. In fact, if everyone was living as long as white people in Shawnee County, we would actually be at the rate of like Kansas or the United States. So we wouldn't be above that line. But our people of color are, as you can see, their rate is essentially twice that of our white population. So they're dying young and they're dying often. And when I think about if we want to improve this outcome and improve Shawnee County, it would not be the white people that we need to focus on. It would be our population of color that we would make the most impact by interventions in our health factors that then lead to these health outcomes. Then just to kind of dive into it just a little bit more, because babies are part of this number too, and this is a priority area for our community health improvement plan. I wanted to point out kind of the same trend that we have our white babies have a lower rate actually of dying, and this is a year or less, dying at it when they're 1 year old or less. But our people of color, those babies, the rate is almost twice our average. And so again, when we are thinking about interventions for our infant mortality rate and improving our length of life, it would be in our populations of color where we would make the biggest impact. Moving on into our quality of life, and so I just kind of put a box around our physical health days and our mental health days here. Our physical health days, I had noted that they're a little higher than our. So actually, sorry, let me explain what this is first. You can see that our number is 3.1. So what that means is that on average, our citizens in Shawnee County are reporting 3 poor physical health days in every 30 days. So you might think in a month, we are feeling badly 3 days out of that month. And then it's same with the mental health days. In a month's time, on average, we have 4, almost 5 bad mental health days. Now, KHI, when they took a look at this, they actually are saying that our physical health days are about the same as Kansas, and so it's actually a positive. They gave us this is contributing positively towards our outcome, 79, but the mental health days is not. It is contributing in a negative way, and it has increased about 1 extra day from our ranking last year. So mental health is certainly of concern for us here in Shawnee County, and I put a little asterisk there that it is also a priority area for our community health improvement plan. Okay, so moving on to the health factors. So here, as we were talking about, our rank is 45, and it has improved, and we are actually in an upper quartile on this, which is good news to me. I am hoping that this means we will be projecting into the future with an improvement in our outcomes. Okay, so Craig had already mentioned that there are big domains, if you will, that go into the factor. So this is the first domain. It's our health behavior. I've put asterisks next to each health improvement priority area, so you can see there's a lot of work that is going on in this area. I wanted to put a little green box around our access to exercise because the Parks Department, and there's a lot of work that the county does, the commissioners do, to give people the opportunity to exercise. And if you look at how we compare to Kansas and the United States. 88% of our population has an opportunity to exercise. Whether they take it or not is a different matter, as you can see on the line above with physical inactivity, but the opportunities are there, and that's parks, that's the trails that are provided, that's the sports events that are offered, and so on.
Doctor,
Yes.
there's some of this information that I know you would be able to gather, such as access to exercise, that they would just be able to pull off a line or go to the Parks Department and see what there is. There's some of this data that you would be able to gather just by surveying the death certificates and seeing what the age of the person was. How are they gathering the information, such as how many mental health days, positive or negatively, you had? The individual health data, are they getting all of that from the primary care physicians? Are they getting that from the health department? Are they getting that from surveys voluntarily done? Who's turning in this data?
I believe that specific measure is the survey, the BRFIS, the Behavioral Risk Factor Surveillance System, which is like a nationwide, routinely done survey. But you're right, we're not asking every single person in Shawnee County how many times their physical health has been bad. It is like a representative sample. And I apologize, I don't know what years this most recent data was taken from, but it's a survey.
So you're dependent upon the people that answer the phone?
That's exactly right.
Okay.
Yep.
And do we believe that that's truly an accurate reflection of our community?
Yeah, I don't know if you want to take a look at that. I will say that it is the same across the state and across the nation, that we are relying on that same sample data. It is a long-standing survey. It's been in place for years and years and years. When I was in school and in training, this was being utilized. And so every method of data collection has its problems and its good points to it. You're certainly doing a good job of keying in on one of the biggest problems of the survey, which is that sometimes busy people or the young people or whoever we're trying to reach, it's really difficult to reach them, and that there could be a bias towards individuals who are easier to reach or more likely to participate.
Well, I mean, if you're dependent upon people that have landlines, I would be hard pressed to find anybody
I don't know.
under the age of
I think
30
they've
that
maybe
has a
evolved a
landline.
bit from it, but yeah, Craig, if you want to say
So
something.
one of the things I think that's important to note on the breakfast survey, and your last comment kind of hits the nail on the head. So 3 years ago, I think maybe 4 years ago, cell phone data wasn't included in the BRFIS, so it was landline. They use an algorithm, so the CDC puts down models, and then each state basically pulls out those questions and then the algorithms for how they ask the questions, how they move through the questions that they ask. And so Kansas pulls those different models from the CDC, and then they do an algorithm basically to get a randomized sample, specific zip codes and areas within the community so they can provide the most equal, kind of equitable distribution of people as possible within the community. So you're never going to be perfect, and you're right, it is who picks up the phone and looks at it. But one of the unique things that I know the CDC is looking at is how to now incorporate in some way potential email or electronic correspondence to increase the ability for those survey responses to come through and analyze that data. So I would imagine some of this data will shift again. You'll see some of those blank spots on that sheet. That's due to how they conduct the survey and things of that sort. But we are very much so reliant on a lot of those national surveys, the American Community Survey that goes into the schools, the YRBS, which is the Youth Risk Behavioral Surveillance, and so those. But we, again, like I said earlier, we take a lot of that data and we combine it with also the qualitative data that we do on the 3-year cycles with our community health needs assessment, and that's the data that we do directly in our community, and we have always had a tremendous response with that. I think our last one had nearly 3,000 responses. Now, granted, 3,000 responses within a very large county, but for a survey like that, that's much better than some of our contemporaries do as well.
That's great. I don't know if that's satisfactory or not, but
It's an explanation.
yeah. Okay, and so then the other area that I was highlighting here was our sexually transmitted infections, which we've already mentioned once before today is one of the sort of, I guess, the family planning program that was started a year ago has been in part addressing this, but also this is on our community health improvement plan as a priority area. And so I did want to just show you this one graph. So this is specifically chlamydia. Chlamydia being one of the most common treatable STIs in the United States. Very common. I think Manya had talked about for that 15 to 24 age group, they're recommending that we screen for chlamydia and gonorrhea every year. Chlamydia is being used here as a proxy because of how common it is, frequently will go hand in hand with gonorrhea. I can also tell you, I know that syphilis is increasing both locally and in the state. So this is just looking at the number of cases per 100,000. And you can see that Shawnee County in red was pretty more or less consistent with Kansas, or excuse me, the United States, which was yellow, up until about 2016, at which point our cases have really increased. And we only have data up until 2020. There's been a lot of talk that first screening kind of went down in 2020, so there was a lot of unidentified, so it may, in the future, may look like there was a dip in STIs, but my understanding is that it's going to continue to go up as we get more and more data in the years going forward. So this, when the Kansas Health Institute takes a look at what as you can see on page 2, one of the biggest drivers towards our health factors in general, the sexually transmitted infections is one of the measures that's hurting us the most. And so we are working on it. Okay, next big domain is clinical care. Craig already mentioned we do really well in this area, so I only have green boxes to point out here. Mental health is still an important and increasingly important issue in Shawnee County, but I do want to show that when we look at the ratio of mental health providers to people, we in Shawnee County have a better ratio than in Kansas or in the United States by quite a bit. And I think that's historically, we have had a strong mental health community here, and so this is a sort of because of that, we still have a number of, or our ratio is still quite good. Whether it's good enough, I think is a debate that I think many would say it's not good enough. We still are in need of providers in a timely fashion. Taking a look at our mammography and our flu vaccinations. So again, Shawnee County in red. So this is looking at Medicare enrollees. So looking at women 65 and older, they need to get a mammogram for breast cancer screening every year. We consistently have been better than both Kansas and the United States, which is great. This does help to catch our breast cancer early, get it treated, and prevent and decrease that early death. And this is something else that, as Manya mentioned, she's doing at the family planning clinic as well. Flu vaccine is the same. So again, we're looking at Medicare enrollees 65 and older, but now it's both men and women. You need to get your flu vaccine every year. So this is looking at people who are coming back year after year to get their flu vaccine. And we have consistently been better than Kansas and the nation. Okay, moving on to the next domain is the social and economic domain. So I just wanted to highlight a few things that I found interesting and were positive, in my opinion. Our high school completion rate, our unemployment rate, and that civic association, as Craig had mentioned before, which here is the social associations. Now, what's interesting, I will point out, I have put a green box around unemployment because it is lower when you look at this from Kansas and the United States, which I think is very important. The Kansas Health Institute is still saying that that is working against us, the unemployment rate, and that if we wanted it to be helping us, we would need to drop that even lower. I don't have a good answer for that, why they are why they would argue that that's still hurting us, but just so you are aware of their analysis on that. Looking, though, at our injury deaths, this is another community health improvement priority area. Injury deaths, as I mentioned before, can be both intentional and unintentional. And so specifically, the CHIP is looking at our suicide death, which is linking, of course, to our mental health. So I pulled this straight from our CHIP, and it's showing just Shawnee County, and it's looking at our mortality rate per 100,000. And in general, I suppose you could say that it's been fairly steady, although somewhere around 2012, 2014, it did seem to increase and is now higher than 20 suicide deaths per 100,000. So when I look at the previous slide to the accidents, or the injury deaths, excuse me, it does seem or appear that about a fourth to a fifth of our injury deaths are from suicide. And so this is a big priority area to decrease that suicide rate down to zero. Suicide is a preventable outcome. Okay, and then finally, we're taking a look at our physical environment. So just, I thought it was interesting what I have highlighted in green, looking at our population and how far they need to drive and driving alone to get to work. They define long commute as 30 minutes or more. So most of our population is driving short distances to get to work. And it would seem that if they're driving longer, then maybe they are carpooling. And so that was certainly a positive compared to Kansas and the nation. But taking a look at our air pollution, we have a higher air pollution with particulate matter. And so they're specifically looking at the smallest particulates that we measure, the ones that can get deep down into your lungs. And we've been improving. So this is looking at that graph. We are again red. I don't know what happened in 2015, 2016. Things looked really good, and then they've popped back up again. So this is also one of the biggest areas that is hurting us when it comes to our health factors, according to the Kansas Health Institute. So air pollution affects our health in a number of ways, both kind of big and small. Air pollution it causes irritation of your mucous membranes. It can give you symptoms that make you feel like you have allergies. You know, you've got that painful, itchy eyes, cough, and so on. But it also actually increases your risk of heart disease, heart attacks, strokes, lung disease. Over time, if you're exposed to air pollution, you can develop lung disease. But it can also exacerbate COPD exacerbations, asthma exacerbations. Children in particular are quite vulnerable to air pollution. And children, for example, with asthma who are dealing with air pollution tend to do poorer in school. You can imagine they're missing school because they can't breathe, or they're still in school, but they're not able to concentrate because they're having difficulty with breathing. Other symptoms of air pollution include, of course, like fatigue, headache, irritability, and so on. So, and then ultimately, it impacts our premature death. So people die earlier when they're exposed to air pollution. This is also not something that impacts our communities equally. The more resilience you have built in, you know, if the area of town in which you live, your overall education and wealth and health makes you more resilient against air pollution. And so it tends to affect populations of color more than it does white individuals, wealthier individuals. So air pollution is something that if we want to make a difference on this, there's a number of ways. You know, cars and vehicles tend to be one of our biggest air pollutants. So when we look at our built environment, looking at how can we encourage walking with sidewalks, our zoning to get our the where you need to be, if it can be closer to your home so that you can walk there or you drive less. Our public transport, is it reliable? Does it go to where you want to go? Is it on time? Does it feel safe? those methods of transport. And of course, the electrification of cars. They don't produce the air pollution. So how do we encourage that movement of our cars by putting electric hookups or chargers in places where people travel or want to be? We also look at our factories and our power plants and the location of where those are situated, and also just the pollution that they are actually producing. And then there are sources of air pollution that are somewhat outside of our control, our wildfires and our dust storms and our agriculture, fertilizer and so on, that affects our air pollution here in Shawnee County. I think, do you want to wrap it up? That was, yeah. Oh, I guess, I thought you had a slide in there. I'm sorry.
Yep.
Yeah.
Missing another slide there, probably my mistake. So, public comments. I'll be the public today. So how do we take this data to action, right? I think that's how we kind of wanted to close this up. And so I've talked a little bit about it throughout the presentation, how we do the community health needs assessment and the community health improvement plan. So the needs assessment is a 3-year cycle, same with the community health improvement plan. We do those on 3-year cycles. These are long-standing community partnerships that we have with Stormont Vale Health. Heartland Healthy Neighborhoods is our grassroots community health coalition. And I'm excited to say that we have also entered into the fold Vallejo Behavioral Health. As Dr. Locke talked about specifically, the mental health has been a priority area, behavioral health, in our community health improvement plan for the last 2 iterations. And so with that being the case, and then also with Vallejo and Family Service and Guidance Center going through their CCBHC accreditation process, part of the requirements for that process is to be engaged in a community health improvement plan and needs assessment. So we will be leveraging capacity with them as well, and then as a part of that FSGC, Family Service and Guidance, to get some additional qualitative specific data to our community, similar to what we do when we partner with Stormont Vale Health. So Commissioner Cook, to your question earlier about getting data, when we do our community health and needs assessment, we are getting data through the primary care clinics for the patients that we see here in our community. We'll be doing the same thing for those who receive services through the behavioral health centers, so we can utilize that data and build it into our community health needs assessment. So we have a better analysis of those community needs in our community to ultimately then get to the point where we publish our community health needs or community health improvement plan. So this is our new community health improvement plan that was published at the end of 2022. This covers a 3-year cycle from 23 through 25. It has the same 4 real priority areas, so behavioral health, access to food, substance use, and then we pull out a specific area to health equity. A couple of the health factors that Dr. Locke talked to: infant mortality. We're looking specifically at the social demographics areas. So specifically, how can we target interventions specifically to help ensure that Black babies are not dying at as high of a rate that they are in our community. The same thing with the sexually transmitted infections. That is pulled out within our health equity section. And then also physical inactivity. So we're looking at creative and innovative solutions and interventions to increase that physical inactivity. I think, as we saw, our access to recreational opportunities is very high. We have an amazing Parks Department, and we continue to try to collaborate with our Parks and Recreation Department as often as we possibly can. But are there other interventions through the Complete Streets that both Dr. Locke and I have talked about, and things of that sort? Safe Routes to School, another initiative that we are partnering with the City of Topeka on, to look at increasing the ability for kids to get to and from school, but then also adults to move around within the community and get access to their clinical care, and as well as to food and other services that they may need. So there's a lot of opportunities. We're excited that this summer we'll be hosting our annual community conversation on the county health rankings. It's a great opportunity to do a similar dive like this with all of our community stakeholders at the table as well. So we'll be looking at that this summer. We'll also be getting a nice update on the large Pathways to a Healthier Kansas grant that is Heartland Healthy Neighborhoods is leading in our community, that's looking at a multitude of different interventions that are hopefully will improve health outcomes and health factors in our community. So as I say, for the, all the people watching online and to everybody in the room, if they're looking to ways to get involved, I would strongly encourage individuals to reach out to the health department or to Sarah Carnes with she's the director of Heartland Healthy Neighborhoods. There are multiple opportunities for civic participation here to make great strides in improving our health factors and health outcomes here in Topeka and Shawnee County. So with that, any other comments that you'd like to make? No? Questions from you all? Any additional questions? All right. Members of the public? Okay. Well, very nice. Thank you so much. Appreciate your time today. Teresa, do you have anything else? Last words?
So again, hopefully we've provided an overview of two very important areas here in our community, both within our health department and the community. We look forward to bringing the fall edition of the Board of Health meeting. I anticipate that we will for sure have our mosquito surveillance, which is going on right now. We will always like to bring that back in the fall and let you know what sorts of things we found or what we didn't find. And then any other items that are of interest to the Board of County Commissioners or relevant items. So thank you again for today.
Thank you very much. All right. We have one last section here. It says public comments. I don't think we're going to have any here. Jim, do you have any comments?
I do not today, but thank you for asking.
Okay. I think we're adjourned, so thank you.